Good morning, I am Professor Louise Wallace and today I'm presenting with Dr. Ned Redmore of the Open University. We are presenting one part of the larger DAPL study. We look at how do services plan for end-of-life care for people with learning disabilities in England. The study is funded by the National Institute of Health and Social Care Delivery Research, and the views expressed are those of the authors and not necessarily NIHR or the Department of Health and Social Care. While we know quite a bit from people with lived experience and families about how services are experienced, we know much less about how people go about planning these services. So what we wanted to find out was how do services plan for end-of-life care for people with learning disabilities? We also wanted to know what services find difficult about planning for end-of-life care, in particular for people with learning disabilities. And also, can we find out what services find that works well so good practice can be spread more widely? We looked in depth at services in 4 areas of England, which are West Yorkshire, Leicestershire, Milton Keynes and South London. I asked our team to suggest people in charge of planning and paying for services in these areas, including those in learning disability services and palliative care, general hospital and community hospital services. I interviewed general practitioners, specialist nurses and service managers who run services and commissioners who pay for them. We found services need to be able to know people are nearing end of life. A senior learning disability nurse said, "You can't just hit the end of life care button." Services need to know how many people they have at end of life care and what their needs are. But we found little evidence, for example, that either learning disability commissioners or hospice services record such data. A GP said, "I don't know how many of our patient cohort have a learning disability. I've not seen that data." Services need to support people to plan for the future, and to do this, they need to know what to do when people's needs change. But because this is not recorded in such a way as service planners can understand the changes in need, these needs do not inform service planning. Healthcare professionals often don't recognise changing healthcare needs in people with learning disabilities. It's not always obvious with people with learning disabilities who may already have a lot of health conditions, but the pattern should ring bells. A learning disability nurse said, "Hold on, you've been to hospital 5 times with this. Do you think that we need to have a plan if this gets really bad?" But that didn't happen. Sometimes this can be because they're young but have conditions older people often don't have. That learning disability nurse said, "I think that people find it very difficult to have a conversation with a 40-year-old as opposed to an 80-year-old. I think it can feel quite difficult for a clinician." Sometimes it's because they don't meet people from minoritised ethnic groups or record ethnicity. A hospice director said, "I think our services are still set up for white middle-class people who can navigate the system, who have digital access and can read English." Some hospice services are working to engage with faith-based communities, going to mosques and having open days and training with local disability providers. Learning disability services often don't have the right equipment to support people at home, and by the time it's provided through social services, it's too late. So people can become stuck in hospitals. A senior nurse said, "He was in hospital for 2 months. He was actually fit for discharge, but there were just so many things that the home needed to get in place." Hospice services aren't making good records of how many people with learning disabilities they care for. This means they may not know if they need to focus more on people with learning disabilities. Learning disability services often don't recognise symptoms or when people are becoming more unwell. One nurse said, "We've got services who say, we don't work with people with learning disabilities, we're not registered to do this." Support staff don't have the specialist training or recognise or provide end-of-life care. A hospice director said, "The care industry now, you go in, you do your bit, and that's it. We no longer have those tea and sympathy visits like community nurses used to do. Those old relationships are really valuable." People might be recognised better through good health checks or digital tools that track their use of health services. A GP said, "But if it's a poor quality health check and health action plan, it's meaningless." This might happen more if hospices and GPs work with learning disability services, share training and expertise, as we found in some parts where this outreach is happening. Services need to begin making end-of-life care plans at an early stage. This would help them to make good decisions when people become ill. Commissioners also need to start planning ahead, finding and paying for approaches that work for people with learning disabilities. There were some examples of this. The hospice director said, "We run pilots. We go back to commissioning saying, that's what services need to look like, and then we try and get funding for those services." There are very few learning disability focused healthcare professionals in general healthcare services in England, but they often are really important for delivering good end-of-life care and commissioning the right types of services. This learning disability nurse working in commissioning said, "I can't find anybody with a similar role to me in the UK." Our conclusions. All services need to make better records of palliative and end-of-life care needs for people with learning disabilities. This will help services and commissioners to make better decisions. Families and support staff often have to speak up for people. This is often harder for people coming from different ethnic minorities. Better recognition of people's healthcare needs is needed. This might come through more specialist roles, digital tools, and improved learning disability health checks. There was a really promising tool in one of the sites which is tracking healthcare data within GP records and predicting when end-of-life care needs may arise. We will track how useful this is in our current research. Thank you.